Thank you for the opportunity, organizers and the esteemed chairpersons and the panelists. So just to start with, I will start with real case scenarios. Most of them have been our and my colleagues' cases as well. So it's a first case is a relatively young Indian male, corporate executive, North Indian, no family history. On opportunistic screening, his PSA was 3.1. Was observed for some time after an antibiotic course. The repeat PSA was 2.9. No LUTs, non-smoker, moderate alcohol. DRE was benign. Ultrasound was prostate was 28. PVR was nil. So largely. So over to Dr. Manav sir, what would you do about the PSA? Would you keep him under follow up? Would you reassure him, get him back after 6 months, get an MRI, get a trust?
See, if we go by the EAU PSA screening guidelines, they are doing a risk stratification with a strength recommendation week. If you are 40 and have 1 PSA or less than that, you are supposed to go the next PSA after 8 years. If you are 60, you have a 2 PSA, 8 years. If anything more than that, then you are supposed to follow it up 2 yearly. I would have put him under observation for a screening of PSA later on.
Okay. So as we had it, and since it was opportunistic and he wanted our advice, and he went ahead with an MRI himself. And on the MRI, there was one Pirates 3 in apical and one into 1 centimeter Pirates 4 in the right peripheral zone. So to Dr. Rajesh Taneja sir, so what would be your ideal recommendation now? I mean, what kind of evaluation would you have suggested if he was with this MRI? Yes, sir. Sir, with this apical lesion and well, we all know that we don't have transperineal at many centers, and most of us rely on the transrectal biopsy. And would you have venture into fusion biopsy any case, or what would be your ideal biopsy choice in this case? Yes, sir. Okay, sir. So, sir, do you tend to follow these high normal PSAs? How do you actually follow these high normal PSAs? What is your practice pattern when you have these? Okay. All right, sir. Or do you suspect another that before you get reassured and you just let them follow up, or you get an MRI any which ways? Okay, sir. Okay. So, is there any comment with respect to the pro-based data that we discussed? Would you suggest anything which was the pro-based data was a study about these kind of patients only, in which the MRI uptake, the MRI, I would say the detection rate was very low. So yes, sir. Absolutely, sir. Absolutely. Yes. All right, sir. Done. So, sir, Manav sir, you have been at the helm of trust biopsy. I've seen you doing trust biopsy in less than 2 minutes. And what is your take on transperineal biopsy? Would you recommend a transperineal biopsy in this case, or a fusion? This is an apical pyrethry also, and transperineal is known to focus that better.
So Vikram, I have a couple of comments to make on this. For a first-time patient, a normal trust biopsy is as efficacious as a fusion biopsy as per literature. Number two, in experienced hands, you're doing an MRI for every patient today. A cognitive MRI trust biopsy is as efficacious as a trust fusion biopsy, which needs an investment of 2 crores worth of a machine. Number three, if you are able to do it in 2 dimensions with a biplanar probe and do the sagittal section also biopsies, I can target almost every area of the anteriors, and I've never found any limitation on trust. Number four, over last 10 years, having followed the practice of only a single shot antibiotic in the morning and a negative urine culture, our infection rates are extremely low. And the last sepsis, which went to ICU, touchwood, I saw almost 7-8 years back.
Right,
trust
sir.
biopsy.
So now you don't use any urine culture or rectal.
I would always have a urine culture. I would always ensure it's a sterile urine culture or it's a 3-day antibiotic coverage if it's a positive urine culture, recalcitrant not getting negative. And then I would just proceed to a conventional biopsy. My routine trust biopsy would come with a single shot of Magnex in the morning 3 gram with a negative urine culture, and we have no problems with the infection rates.
So, as an insight from Prevent Trial, and we have our own USI consortium coming up with its own result. So, what is what is the rectal swab? I mean, it can grow multiple bacteria. How do we go about?
It does surely say, as per these papers, that because of
any practical experience with rectal swab. Yes, sir. Yes, sir, it doesn't. Manav sir, do you have an antibiogram of your hospital? I mean, this is what is suggested. And with ciprofloxacin resistance as high as 90% in some of the institutes in India.
I would just like to make a simple logical comment, and I do not have a scientific backing for this. We all exist with E. coli in our rectums, right? They are common cells. They are not pathogens. By over-treating with antibiotics, we are replacing the normal friendly flora with a difficult flora. So rather than going into over-antibiotic kill, we go into judicious antibiotic, and that actually leads to a better performance of patients. Though, for having said that, I do not have a specific knowledge. My hospital has started up new. I do not have a specific knowledge of antibiogram for our own local area.
Do you do perennial biopsies?
No, I don't. As of now, no.
Do you plan to do?
A lot of people are making a noise. The market may force me to.
But do you do post-procedure antibiotic how many days?
Oh, yes, we do surely give that for 5 days.
Okay, sir. So it was a low-risk disease. 2 of 14 cores were involved. That too on the right side, the Gleason, the Pyrad 4. Tumor percentage was 9%. Young disease, young guy, low-risk cancer. So what will be the treatment option, sir? I mean, what would you consider? Sir, Sanija, sir. I mean, obviously also to the RT colleagues, but what will be? Yes, sir. Yes, sir. Mm-hmm. And what would be your protocol, sir? Follow-up protocol if he were to be an AS candidate? Every 2 years. So in your, okay, sir, all right. Fine, sir. So any RT comments with respect to PSA study that we had, or the in which we were battered about the results of RARP?
As sir has already commented, the patient is young and looks, if he's compliant to follow up, yes, definitely will suggest for an active surveillance, because that also is a very tedious process. One should understand. We'll give him the options of, like sir said, for RARP, but yes, also the patient is a candidate for, if chooses a radiation as a region, he is a candidate for a ultra hypofractionated regime, SBRT of the prostate.
So, ma'am, with respect to outcomes of the one, oncological outcomes obviously are comparable, and with respect to the morbidity outcome in a young patient, are they likely to increase over time? Because he's 50 and
see the
over 20
long-term
years.
data, as Dr. Sham has also presented for these, the efficacy wise, it is showing that these are comparable. And the phase A trials, actually, that is a little bit debatable. There are certain things which we critically look into. We need to look critically into the phase A trial. But yes, we need to wait for more than 10 to 15 years, yes, to see the long-term toxicity as well.
Okay.
Any comment from Dr.
So the follow-up as of now is not that long for us to very confidently say that, yes, it is a standard, but the results seem to be encouraging. And
Okay.
if the patient wants to
So if the
take that
patient
into
was
consideration.
65 years old, would that be your choice and he was not?
So I would inform 65-year-old also in the same way I would inform a 45-year-old, because it's the patient's choice what he wants to say. If a 65-year-old is ready to come on a daily basis and he understands that long-term data is not available for the SBRT arm, then I would go ahead with that.
Thank you.
Though it looks encouraging, yes, in terms
Okay.
of toxicity as well as early as well as late as of now, and the oncological outcomes are comparable.
I'll just make a comment too. So we are looking at the pad usage for the surgical side. I would say the bowel toxicity 15 points more in PSA. That also looks unusual, because we have meta-analysis which says 0.4 to 1% of long-term GI toxicity, whereas this one shows a 15-point rise.
So maybe both
if
the
we are going to
surgeons and
offer
the radio.
radiation, if the patient accepts it, then obviously stereotactic SBRT becomes the at least a choice that we have to give for these patients.
Manav sir, any change of plans?
Active surveillance, 48 years, normal sex life, normal continence, normal life, active surveillance any day.
Okay, but you have to.
That's the only choice in my opinion.
Okay, sir. Yes, sir. What about HIFU?
As of now, the data we have seen, HIFU data is not very promising. The failure rate was at 1 year around 46%. So in this scenario, I would suggest it is still experimental.
So apart from this study, sir, I mean, was there any, do you suspect? So in that study, I think, although it was a prospective and a completely good done randomized study, do you think there was an error on the side of, it was a small study, the number was not, it was not a multi-center study, it was just a, I would say more of a pilot study.
Yeah, and follow-up was also not very great.
Not very long, and they biopsied.
The contradictory results was shown by the another paper presented in.
Although it was an MRI guided HIFU. Yes, sir, there was erectile dysfunction.
So the contradictory result shown by another paper needs to have another arm. It only compares surgery vis-a-vis HIFU. You need to have an active surveillance arm for these patients. All the patients selected for HIFU are actually the patients that should have undergone an active surveillance.
Yes, sir.
No, about that, sir, so that trial is going on. So we'll have results for
the
active
trial
surveillance.
I think Ashwin presented, it was only a single arm trial.
Yeah, the one that I presented was a single arm, but there is a head-to-head comparison between active surveillance and HIFU that's going on, and we'll have the results soon. The results have been submitted, but it's not yet in print. So let's just wait for that.
Just make a comment that any treatment you do, either surgery or radiation, patient is going to have some side effects, and he's a young patient. In focal therapy, he will not have side effect. You may buy some time for a good quality of life. He may end up with the surgery later on or something. That is why focal therapy makes a huge sense in young patients. That's the practical thing.
Thank you, sir. Thank you for your comments. So case 2, he's a 68-year-old army veteran, mild LUTs, well-controlled, hypertension, well-controlled. and no surgical history. His initial PSA October was 6.5. So this is a recent patient. His DRA was benign. His repeat PSA was 5.8. This was Medanta. He underwent an MRI. There was again a highly suspicious left-sided pyrite 4 lesion and a right-sided base pyrite 3 lesion. So he underwent fusion biopsy with systemic biopsy in January. The histopathology along with IHC was suggestive of benign disease, and he was on follow-up. But 3 months later, again, his PSA was 7.3. So what would be your take at this, sir? So what would you recommend, Rajesh, sir? I mean, these were all the options which he's not a diabetic, sir. So he's non-diabetic. He's well-controlled hypertensive. He's completely fit. So yes, sir. Would you recommend a slide review? Mm-hmm. Yes, sir. So sir, with respect to that, so what is your experience of PSA MRI in pre-diagnostic workup or whenever you order? So, sir, what was your negative predictive value, or I mean, false negatives? Any false negatives, positives in those? Yes, sir. Okay. Which were false positive. Any change of plan, sir? Manav, sir?
A repeat PSA after 3 months.
Repeat PSA after 3 months. All right. So this is after 3 months.
Another repeat PSA after 3 months to look at the doubling velocity.
Okay. So any point of reviewing the slides? Would you like by an expert uropathologist?
I did think over that. Possibly you could either review the slides also and wait for him to go for a repeat PSA after 3 months. And somehow we have still seen in Indian subcontinental scenario, if you put them on basic antibiotics for 3 to 4 weeks of course, these next.
This is post antibiotic. This is my patient.
Then a repeat PSA after 3 months.
PSA after 3 months. So, sir, do you think that we are anyway on a pathway where we can go biopsy free in prostate in next decade? With AI coming in and MRI, with AI coming in, and we have PSMA MRI also.
As of today, Vikram, the problem is, one, it will have medico-legal implications with the confidence of the society in the medical sector at an all-time low, because the biopsy is a standard of care, albeit not in kidneys and kidneys, but in this one. Secondly, you also have to realize the implications of side effects for radical treatments in these cases can have menacing effects. So I would always still bank on biopsy. I don't think so. The prime time has still come for a biopsy-free pathway.
So would you do a fusion in such cases? Would you do a HIFU in such cases? If you were to go on that path, and if you have a highly suspected nodule, which is sterilely or plateaued high PSA with a repeatedly suspicious node,
I will still wait for the biopsy proof. If the report stays
Okay.
benign, I'll just simply do nothing.
Okay, sir. Thank you, sir. Ladder, yes, sir. So we are not prime time. We still have some time to go. So so yes, I think so. Yeah, ma'am, any comments, please? Mhm. Absolutely, ma'am.
So only when the patient chooses for surgery, we'll have all those prognostic factors in hand. But if a patient chooses non-surgical pathway, yeah.
Can I make one comment?
Yes, sir. Please.
While talking about this biopsy business, now can I include now genetic studies like
Absolutely,
CTC and
sir.
ctDNA,
Absolutely.
which is going to
Decipher-
be the thing which is going to be there?
Decipher
In fact,
score.
it's knocking on our doors right away. And there are now groups who are talking about this CTC and ctDNA. Now, whether to do into the practice, maybe the time it will be there in about a year or so. So I think this is one area needs to be addressed. And I think at USI level, perhaps we should address this issue because you have got a large number of people, large number of patients, large number of institutions who can do that and come out with an answer in about next 2 years' time. Thank you.
Sir, sir.
Now, I started 2 years ago, we got 0 number of patients of the 25. We got included patients in the registry process we had 47 years we have patients who have many history of disease, but all the other data they did not find any history of that. So we look at the genetic data. You are getting your whole country's HRI management. If I don't have these Indian problems, they are not getting as much. So we have to take the case of because of our data. We got it from net people, right? We got it from net people.
Yes, sir. 5 minutes we have.
The diagnostic part of a molecular, the thing which is evolving, which we are also doing is RNA-based test. If you do circulatory RNA, for that you require 2 ml of the blood, while circulatory DNA or cDNA, cell-free DNA, you require 20 ml of blood. And we have already done this on the patients who had radical prostatectomy. Now we are doing the diagnostic. When we do the fusion biopsy, we do this test, we express the gene, and that goes to the, this is just part of the trial, not in.
So you compare it to the biopsy RNA also?
Yes. So later on, like PSA, we probably can have this and maybe get away with biopsy. These things are coming up.
Yes, sir. So even in the study which was done, one of the post-RARP specimen was non-cancerous. So yes, so it was non-cancerous, and we must highlight that. And it was in PGI, he could get away with it, I think. And so we have all covered this. It takes away the false negatives, the addition of PSMA PET-CT in a prospective trial, preoperative. So we are far from a prime time. So this is essentially a high-risk disease, a nodal positive disease, PIRATE 5, EPE, Gleason 7, 10 of 12 course, PSMA PET-CT, locally advanced. There was pelvic nodes were positive and no other disease. I would like to have the opinion of my radiotherapy colleagues. What is the evidence, and can you take us, because most of the times these studies make little, if not much sense to hyperfractionation and moderate fractionation and ultrafractionation and SBRT. Mm-hmm.
Toxicity, as we have seen in the various trials, phase B and the prime trial, we have the initial data. Also in the short trial, the acute toxicity and up to 4 to 5 years toxicity, both are almost similar. So there is no extra toxicity if you are going for extreme hypofractionation. Yes, the follow-up as compared to mountain, which is on 10 to 15 years, that is extreme hypofractionation.
So I'll make a comment here. So this patient falls into high risk, nodes are positive. So number one, we have enough level 1 randomized evidence that in high risk, we have to treat the nodes.
No, absolutely.
So
No doubts about it.
About that. The duration of ADT is also clear, that it has to be at least 2 years. Coming to the RT fractionation, whether it should be SBRT, whether it should be conventional or moderate. So conventional is 2 gray per fraction, the long one, 7 to 8 weeks. So all of us have mostly moved away from it, and we are doing moderate hyperfractionation as seen in POP-RT trial, also 68 in 25 or 60 in 20, like moderate hyperfractionation. When we go to SBRT, the dose per fraction is much higher. It's 6 to 7 gray per fraction, and many trials are also using 8 gray per fraction. Now, if you look at the acute toxicity, as you increase the dose per fraction, the acute toxicity rises. So we need to balance where we have it. The acute toxicity, the late toxicity, and the control. Because when the dose per fraction goes high and we do SBRT, the PED also becomes high. So we have better oncological outcomes. What appears to be good from the existing data, a fractionation of around 6 to 7 gray per fraction, that is like 36.25 or 35 in 5 fractions. But for high risk, whether it should be done or not, we do not have enough data. The prime is also talking about acute toxicity, the 90-day toxicity. We do not have the long-term toxicity.
Long-term toxicity.
So for a high risk, we should be using moderately hyperfractionation schedules along with ADT, which is the current standard. And SBRT, I don't think it is too early to offer SBRT.
Now, how are the finances? How do the finances come out to be? Are they equivalent to?
Bit different. SBRT is slightly more expensive, but not much. Maybe differing from city to city, it may be 1 to 1.5 lakhs difference from the routine IGRT of moderate hyperfractionation and SBRT that we do.
I think we have already spoken about the incontinence data about in the PSA trial as well as the PSA trial. So this is about a salvage increase in PSA 0.4 was EP was positive unifocal. So sir, Manav sir, what would be your take on this? PSA 0.4 9 months after about, or 9 to 12 months after RARP doing fine. PSA suddenly is shot from 0.08 to 0.4.
It is a salvage plus.
Salvage plus. Okay. So any change in plan, sir? Rajesh sir. So with this, so he was Gleason 4+4. Any with respect to the trial, formula trial, do you think these advanced ARIs are gaining role into advanced, as Kulkarni sir pointed out earlier? Yeah. Thank you. Thank you. I think this last was to do with the recent trial, FOXPRO trial and HIFU. I was just wondering why Fusion has such a poor outcome in this trial. And I think the jury is still out. The prospective trial still has to give out its results. And I think Jiten will come us and tell us. Thank you, sir. Thank you for the opportunity. Thank you to all the panelists. Thank you to the chairperson. Thank you to...
Take it. So just a question to the uro-oncologists on the panel. We had a case about the low-risk prostate cancer, and when, of course, we all agree that active surveillance would have been the first choice. But we come across patients who want to go any active treatment. So if the patient comes to you and you talk about prostatectomy, of course, talking about active surveillance, would you tell them to see the radiation oncologist also in your practice?
Yes, we all do. We all do.
It is a medical
We all do.
requirement.
We all do. We all do.
We don't see so many consultations like that, but I'm happy to know that on stage is saying. Of course, that's
And now we add genetic markers also. We get genetic evaluation also when we get a young guy.
Yes, of course. And generally, they don't come to us directly. They come to us only when a uro-oncologist refers to us. We would accept that. And another quick comment, like in gynec malignancies, cervix especially, we have accepted that going single modality is better than going with both local modalities. So just a perspective that when in high-risk cases, when we have a feeling that this patient is going to require salvage at some point of time, maybe we could upfront radiation is a very good option wherein we are avoiding one local modality. Just a comment.
Yes.
It's a patient had indication like prostate. So we would still offer surgical therapy because once you have a patient that advances post radiotherapy and consultancy to manage the structure, and we know what to do.
So the morbidity of sitting prostate,
Yeah.
that is what our problem is. Post-radiotherapy.
Could you allow one comment? The case where you had a negative biopsy and with a rising PSA, and sir alluded about the genetic test. I think the correct situation, the situation that we have in front of us is a rising PSA and a negative first biopsy, similar to that. So there are some tests which can be done, which is not the HRR gene mutation and all. I think that's mainly for high risk and metastatic disease. We can we could have utilized the urinary PCA3 or the confirm MDX.
Decipher also we could have used.
Decipher is used in a post-biopsy setting to decide whether treatment has to be given or not, to the best of my knowledge. So confirm MDX uses epigenetic changes around the biopsy, in the biopsy tissue, to decide whether a repeat biopsy is likely to give us a malignancy. So I think those are the tests that have to be applied.
I think confirm MDX and PCA3 are not there in India right now. Yeah, so PHI also, yes.
One question, since you mentioned about the strictures post-radiation, in practice, how often do you see post-radiation strictures, provided it has been done in a proper MRI guided?
Reasonable.
So can you
volume.
point towards the data in Indian context or any third world context, because that will be very important. And yeah, any trial publication that.
See, the thing is, only the patients who would develop a stricture would go to them. The ones who would not develop a stricture never would.
That is precisely I'm telling you. That's a confirmation bias and it's a selection bias. That's why I'm asking for published data. What percentage of patients? Don't say that I see a lot.
I'll
tell you, post radiotherapy, urological intervention, and it requires around 18 to 20%. Just hear this, because a lot of radiotherapists are there. So post radiotherapy, if patient is actually having recurrence in the prostate, salvage treatment for that is HIFU nowadays. It works very well. And in practice, we have done few of these patients and they have no morbidity if you do the HIFU. But if you do the radical prostatectomy, salvage radical prostatectomy after radiotherapy is associated with 100% incontinence.
So we had interesting discussion and a good session. I would request Dr. Rahul.